Hi everyone. This is my presentation on amyotrophic lateral sclerosis, or ALS, also known as Lou Gehrig's disease. So what is ALS? ALS is a motor neuron disease affecting only somatic motor neurons from the peripheral nervous system. Both the upper motor neurons and the lower motor neurons degenerate or die and stop sending messages to the muscles. Without those messages, muscles are unable to function and gradually weaken, start to twitch, and waste away. So the etiology of ALS can be broken down into either familial or sporadic. For familial ALS, there are genetic factors that can cause the diagnosis. There's also sporadic cases, and these can be because of a glutamate insufficiency, metal toxicity, autoimmune factors, or viral infections. And the glutamate insufficiency is what researchers believe to be the most common sporadic reason for developing ALS. And this is when there's an insufficiency in glutamate. These glutamate are basically nerve cell messengers, and when there's not enough of these glutamate, there's not enough messengers going to the muscles to tell them what to do. So for the progression and prognosis, ALS is a very rapidly progressing disorder. Usually clients will die within 3 to 5 years, and only 10% of people diagnosed with ALS will survive for 10 or more years, and deaths are usually due to respiratory failure. For the signs and symptoms, weakness usually will begin to present in hands, feet, and limbs. There could be slurred speech, trouble swallowing, muscle cramps, twitching in arms, shoulders, tongue, decreased postural control, difficulty walking, and an overall decreased participation in ADLs. When we're documenting or reading any documentation with these clients, with regards to their signs and symptoms, we may see things such as paresis, myoplasticity, hyperreflexia, Babinski's sign, atrophy, fasciculations, and fibrillations. Diagnosing ALS is extremely difficult, especially within the first year, because signs and symptoms start off kind of mild and progress to a much more severe case. And a lot of these symptoms mimic other neurological conditions. So ALS is actually determined by ruling out all of those other neurological disorders first. Some of the tests that can be done include EMGs and nerve conduction velocity studies, blood and urine studies, spinal tap, radiographs, MRI, and muscle biopsies. For risk factors, usually clients who are diagnosed with ALS fall between the ages of 55 to 75. Men are more commonly diagnosed rather than women, as are Caucasians and non-Hispanics. And research has shown that military veterans are actually 1.5 to 2 times more likely due to exposure to lead, pesticides, and other environmental toxins. Again, the two cases of ALS, either sporadic or familial, sporadic cases are about 90%, and there are 5 to 10% that are recognized as being familial, with 25 to 40% having a defect in chromosome 9 open reading frame 72, and 12 to 20% having a mutation in a gene producing enzyme copper zinc superoxide dismutase 1. For neurological impairments related to ALS, we have the progressive bulbar palsy, which is the bulbar form, and this involves the corticobulbar tracts and the brainstem nuclei. Symptoms include dysarthria, dysphagia, facial tongue weakness, and atrophy. There's also the progressive spinal muscular atrophy, which is the lower motor neuron form, involving just the lower motor neurons in the spinal cord and sometimes the brainstem. Symptoms of this include atrophy of the limbs and trunk. So this might be one of the impairments where you would especially see some decreased postural control. There's primary lateral sclerosis, which involves upper motor neurons and the destruction of cortical motor neurons, corticospinal, and corticobulbar regions. These symptoms include progressive spastic paraparesis. Now, with the 10% of familial cases, there's also an increased risk for frontotemporal dementia. The presence of C9orf72, which makes up the larger majority of familial ALS, is present in both frontotemporal dementia and ALS, so significantly increases the risk of developing either or both of those diseases. There is some medical management. The FDA has approved some drugs for managing the signs and symptoms. Riluzole is one, which decreases the levels of glutamate, balancing those levels of the nerve cell messengers to get the messages sent correctly to the appropriate muscle groups. And there's also edaravone, which slows the decline in clinical assessment of daily functioning. With the signs and symptoms present, clients will probably also experience pain, depression, and sleep, which they can also have medication for either over the counter or prescription. And as this disease progresses, they may require a ventilator for breathing and a feeding tube. Scientists right now are actually developing ways to take skin or blood cells from an individual with ALS and turn them into stem cells, which are then capable of becoming any cell type in the body, including those motor neurons and other cell types that might be involved in this disease. For the OT evaluation, we first want to get the occupational profile, and this can be done via an interview, either formally or informally, depending on the facility and setting. It's really important to involve the caregiver and or family members because this is such a rapidly progressing disease. The client is really going to need help and eventually will become dependent. So it's important to make sure that the client and the caregiver and or family really understands the diagnosis and you get an understanding for what their expectations and goals are going to be for the diagnosis. So the COPAM is a great assessment to use during the evaluation. Use of the COPAM can assist the person with a neurological condition to identify daily tasks that they may want to do, need to do, or is expected to do, but they cannot or they are not performing them to their satisfactory level. This approach presents the unique concerns of OT, thus ensuring efficiency and promoting increased effectiveness of OT intervention with patients. It also captures the unique domain and focus of OT. Another assessment to consider to use during the evaluation process for a client with ALS is the performance assessment of self-care skills, or the PASS. It breaks down into 4 domains, which are functional mobility, ADLs, IADLs, and that is even further divided into both cognitive and physical. It's performance-based and client-centered and has a great high test, retest reliability and inter-rater agreement. For the areas of occupation impaired, we're really looking at every occupation listed within the OTPF. And these ADLs and IADLs might start off just being minorly impaired. We may look at some compensatory techniques and adaptations to incorporate with these clients as they begin to lose weakness and range of motion. We're also going to be looking at rest, sleep, play, leisure, social participation. As these signs and symptoms progress, they're going to have a decline in participation because they're going to lose function and independence. So it's really our job to make sure that throughout this span of their diagnosis, whether it's 3 to 5 years or those 10 years, that we are really looking at a holistic perspective of these clients in order to encourage them to participate in any way, in any meaningful activity, so that they can really live purposefully and meaningfully whatever way they can. For the models of practice and frames of reference, again, I think it's important to pull from as many as we possibly can because this is such an in-depth and quickly deteriorating diagnosis. So the psychodynamic frame of reference is a great one to start to use. This is a diagnosis that people get, and the prognosis of it is death. So the psychodynamic frame of reference breaks intervention down into 5 categories, things to look at, including social participation in relationships, emotional expression and motivation, self-awareness, defense mechanisms, and projective arts and activities. The occupational adaptation model is another great model to consider because it is an interactive process between a person and his or her occupational environment, and it can also be applied across the developmental lifespan with the holistic application to a variety of populations and therapeutic needs. And finally, the model of human occupation has a focus and engagement in occupational behaviors that maintain, restore, reorganize, or develop an individual's capacities, motives, and lifestyles. It also believes that through participation in therapeutic occupations, persons can transform themselves into more adaptive and healthy beings. These are my references. I look forward to any questions and comments from you. Thanks.